Bismillah ar-Rahman ar-Rahim. Dear colleagues, it is my pleasure and honor to meet you in the third webinar of basic endoscopy learning. And in this webinar, I have the pleasure and honor to share my great professor and mentor, Professor Mazen Naga, the head of endoscopy unit in internal medicine department, Cairo University. And I have the pleasure and honor to have my dear colleague, Dr. Shayma El-Kholi. She will talk us about ESCD, when to ask for or when to refer a patient for endoscopic submucosal dissection. I will start with my lecture. It is about 25 minutes. About endoscopic ultrasound, tissue acquisition or tissue samples. And in this lecture, I will try to spotlight on some of the tips and tricks regarding this technique. Actually, EOS-guided tissue acquisition have become integral to the diagnosis and staging of gastrointestinal and non-gastrointestinal malignancy, and actually it is the real advantage over other imaging modalities as CT and MRI, because in most instances, tissue is the issue. Our agenda to get today is the indications, contraindications, complications, some technical aspects, to do FNA or FNB, and at the end of the lecture, we will have a half an hour of free discussion with me, Professor Mazen Naga, and Dr. Shayma El-Kholi. The classic indication for endoscopic ultrasound FNA is pancreatic lesion. This is the first and the classic indication of tissue sampling. Sampling of the bile duct in case of bile duct strictures, sampling of abnormally thickened gastrointestinal wall, and sampling of subepithelial lesion, and sampling of adrenal gland masses, lymph nodes, retroperitoneal or peritoneal masses, and posterior mediastinal masses. Let us talk about two of the non-classic indications of tissue samplings. And I think this is very important. The first one is GIT pathology, when there is a suspected GI wall growth and the endoscopic biopsy is negative. Not uncommonly, we find this picture during upper endoscopy. Markedly thickened gastric folds in the gastric fundus and the body with nodulations. This picture is highly impressive of a malignant lesion like adenocarcinoma or lymphoma. But endoscopic biopsies with usual forceps, sometimes and frequently in up to 50% of cases, in case of adenocarcinoma or lymphoma, especially lymphoma, but come back to be inconclusive, just inflammatory lesion. Many of these cases were referred for endoscopic ultrasound to have an idea about the wall thickness and regularity. Here, this is the endoscopic ultrasound of this lesion, and this is the normal wall of the GI from the stomach, esophagus, duodenum, or the rectum. The normal wall is about 3.6 millimeters, say 4 millimeters, and consists of very distinct 5 layers, 3 hypoechoic layers with 2 hypoechoic in between. So the most hyperechoic is the mucosa, muscularis mucosa, submucosa, muscularis propria, and serosa. Here in this lesion, we notice that there is marked irregular thickening of the gastric wall, even if it is replaced by a soft tissue mass involving all layers and extending beyond the serosa by pseudopodia, there is complete loss of wall layer structure. So this lesion is highly impressive of a malignant lesion, whether adenocarcinoma or lymphoma, based on endoscopic picture and also on endosonographic picture. But the problem is that conventional biopsies are repeatedly negative. So we can say that the thief is there, but we can't catch him. Then what to do for histopathological diagnosis? Some recommend several endoscopic biopsy from the same point. That is what known as biopsy over biopsy technique. Some recommend doing jumbo biopsy by jumbo forceps. I didn't use it before. Some recommend snaring of a prominent part of the lesion. This is very, very yielding and very effective, but sometimes carries a little risk of bleeding. Then why not to do EOS guided fine needle aspiration? It is a very simple and very safe maneuver because the echo endoscope lies close to the markedly thickened gastric wall, no intervening vessels, no intervening important structures. So it is very safe to do sampling of that markedly thickened wall. This is the lumen and this is the thickened wall. The normal wall thickness is about 4 millimeter. This is more than 12 or 13 millimeter. We can do it by fine needle aspiration needle, or better in these instances, it is better to do with fine needle biopsy, not fine needle aspiration, to obtain enough material for histochemistry or immune staining, because in these instances or in these patients, we are suspecting adenocarcinoma or lymphoma. So it is very easy to do EOS-FNA. And a nice trick here is when you are in contact with the thickened gastric wall, try to do a little bit downward deflection by the big wheel. Downward deflection will bring the echo endoscope more parallel to the wall, so we can travel for a longer distance inside the wall to obtain enough tissue. So I think this is a very good and very valuable indication of EOS-FNA or tissue sampling. In Cairo University, we did a very nice study on 92 cases with diffuse wall thickening, but with negative endoscopic biopsies. The sensitivity of EOS-guided FNA in that case is 83%. So the EOS-FNA can diagnose 80% of cases of gastric adenocarcinoma, gastric lymphoma, and very few cases of eosinophilic gastroenteritis. And the specificity is 100%. So this is a very nice indication of EOS-FNA, markedly thickened gastric wall with negative usual or conventional endoscopic biopsy. Another important job of EOS-FNA is biliary strictures. When we find a biliary stricture, the first and most important question is, could it be malignant? And the second question, where is the stricture? Is it a proximal one, hilar stricture or near the porta hepatis, or it is a distal CBD stricture near the papilla? Both are totally different. 80% of the proximal strictures are malignant, distal cholangiocarcinoma, and it is usually in the form of diffuse wall thickening of the proximal. The proximal biliary stricture is malignant in about 80% of the case, and the proximal stricture is usually in the form of diffuse wall thickening, not in the form of the mass. So it is difficult to be diagnosed by FNA. The sensitivity here of FNA is only 60%, and the negative predictive value is 50%. So here the modality of choice after doing MRCP and MRI, here the first choice after that is cholangioscope and spyglass. Or during ERCP, we can do bile cytology or brush cytology. This is in contrast to the distal CBD stricture. It is 50 to 60% of these strictures are malignant, distal cholangiocarcinoma, and it is usually in the form of solid masses. So it is more easy to be diagnosed by fine needle aspiration. The AUS sensitivity here is about 90%, and the negative predictive value is about 85%. This is an example of distal CBD stricture. Here the echo endoscope is located in the second part of the duodenum, upper second part of the duodenum, and this is the pancreatic head, and this is the distal part of the common bile duct, and this is the lumen of the CBD. Here we notice there is not only marked thickening of the wall, but also mounting to a mesh formation. Although it is a small mass, but it is a mass. So it is very easy to sample this mass by FNA or FNB. So the distal cholangiocarcinoma are usually in the form of a mass. So it is very easy to be sampled by endoscopic ultrasound FNA. And here EUS is the first modality of choice after, of course, doing CT and MRCP. So it is very easy to do it, and the yield is very high. This is in contrast to the hilar stricture. Here we are in the porta hepatis. This is the liver, and this is the region of the liver hilum or the porta hepatis, and this is the portal vein, and this is the hepatic artery, and here this is the upper or the proximal part of the common bile duct with a stent inside. You notice that there is minimal thickening of the proximal CBD. It may be a malignant stricture, very early cholangiocarcinoma, or it may be an inflammatory stricture like ulcerative, like sclerosing cholangitis or autoimmune cholangitis in IgG4 related disease. A part of IgG4 related disease, autoimmune cholangitis. Of course, it is very difficult to sample this wall because it is away from the echo endoscope. There are many intervening in important structures like the hepatic artery and the portal vein. And also the wall is very minimal. How can I do the to and fro movement inside this minimal wall? So here, the modality of choice is cholangioscopy or spyglass. Here, another trick is to try to sample a nearby lymph node. This is a nearby lymph node in the porta hepatis. Actually, it looks a benign lymph node because it is elongated, flat lymph node, and not so echopoor with preservation of the hyperechoic hilum. But if I sample this lymph node, and this lymph node proved benign, then it is mostly a benign lesion. But if this lymph node is malignant, then sure, it is a Klatskin tumor or proximal cholangiocarcinoma. This is the portal vein, and this is the hepatic artery, and this is a porta hepatis lymph node, and this is a proximal common bile duct with minimally thickened wall. These are two examples of a hilar stricture with nearby lymph node. Here, this is a previous case, the lymph node looks benign, but here this lymph node looks very malignant because it is rounded rather than elongated, anechoic or more black with loss of hyperechoic hilum. Here we can do EUS-FNA of the porta hepatis lymph node in the two cases. This is very near to the echo endoscope, no intervening structure. This case proved to have a benign lymph node, but this case proved to have a malignant porta hepatis lymph node. So these patients sure have a malignant hilar stricture, Klatskin tumor, proximal cholangiocarcinoma. So sampling of a nearby lymph node may give an indirect evidence of malignancy. Okay, then we come to the contraindications. There are absolute contraindications and relative contraindications. The absolute contraindications are inaccessible lesion or large duct and vessels intervening between the echo endoscope and the target. And if the primary lesion is interposing distal lesion, as we'll see later, or of course fine needle aspiration will not alter the management. The relative contraindication is anticoagulation or antiplatelet. You can stop it for 5 days or 7 days and replace by fractionated heparin or low molecular weight heparin, and discontinue it 12 hours before the maneuver. But after we do so, it is better to use 22G needle, thin needle with minimal passes, 1 to 2 passes. Some tricks in EUS FNA. Try to avoid traversing a vein for fear of bleeding, or traversing an obstructed duct like the common bile duct. If there is no stent, I fear to pass through the common bile duct because this may induce infection and cholangitis. But if the patient is stented, this is a safeguard mechanism against cholangitis. And I try to avoid passing through the pancreatic duct because this may induce abdominal pain and pancreatitis. And never traverse a major artery. You can, in some instances, when you are obliged to, you can transverse a vein, but the artery, the pressure is very high. And major arteries may be atherosclerosed, and this may induce a break aortic dissection, for example. This is an example. While I am in chest in the mediastinum, this is the aorta, and these are malignant looking lymph nodes. Never pass through the aorta to sample these lymph nodes. Some do it, but it carries a high risk of bleeding and high risk of aortic dissection, and there are recorded cases of aortic dissection after traversing the aorta to reach a target behind. And this is a nice example of a malignant looking pancreatic head mass, and this vessel interposed between the duodenal wall and the pancreatic mass is the gastroduodenal artery. Here are the mesenteric vessels, mesenteric vein and sphenomesenteric vein and sphenomesenteric artery. It is away from the path of the needle, but the artery which is interposed between the echo endoscope and the mass is usually the gastroduodenal artery. Here, if I pass by the needle like that, it may hit the gastroduodenal artery and induce bleeding. So it is better to avoid passing through this vessel. I can manipulate the echo endoscope to find a window. Here, this is the gastroduodenal artery, as evidenced by the pulsed wave Doppler. And here, this is the needle. I try to locate the needle away from this vessel. Take your time. Don't be in a hurry. But the most important is to be safe. Here, this is the needle. Now I pass behind the artery. You see, this is the gastroduodenal artery, and this is the path of the needle. You will find some window to avoid traversing the gastroduodenal artery. Another trick is don't sample a distant lesion behind a primary lesion. As in this case of markedly thickened wall of the gastroduodenal junction. This is the wall of the gastroduodenal junction. Looks like adenocarcinoma mostly. And this is a lymph node. This lymph node may be benign, may be malignant. Don't sample this lymph node because you should traverse through the malignant looking wall. Because if this lymph node is benign, and while you are passing through a malignant lesion, you can translocate some of the malignant cells to the lymph node, so increasing the staging of these patients from N0 to N1. Try to find a window to sample this lymph node without passing through the primary lesion. Actually, in this lesion, I can't, because the lesion is so long, so extensive, so there is no window to sample this lymph node. So I sampled only the wall, and this is enough for diagnosis, and I can sample this lymph node because I shouldn't traverse a primary lesion to reach a distant lymph node. This is a very nice case which I'd like to share with you. A very difficult case, one of the difficult cases I had ever seen. This female, I think it is 45 years old female, complaining of epigastric pains, and CT revealed this small mass at the neck of the pancreas at the level of the venous confluence of portal, splenic, and superior mesenteric vein. So this is a mass, a very small mass. It is about 9 millimeter. There are 4 difficulties in this mass. Actually, this lady under EUSFNA before, and the sample is inconclusive, so it was referred for another trial of FNA, because it is very important to know the nature of this mass. Actually, there are 4 difficulties in this lesion. The first one, it is small, is about 9 millimeter, but this is not a matter. We can sample a very small lesion. The second, it is away, it is deeply seated in the pancreas, it is away from the endoscope, and this is not so difficult because we can extend the needle to reach any site we want. But the real difficulty is that this lesion was very hard, and it is located in a normal healthy pancreas, which is soft. So when the needle approaches the upper aspect of the lesion, it is pushing the needle or shaking the needle and not moving through it. What to do by then? We can do the very nice technique of door knocking technique. What is a door knocking technique? The door knocking technique is that when you reach the upper aspect of the mass, then you can do shaking movement as we will see together. Okay? Have a look with me. Here the needle is at the upper aspect of the lesion. I tried to push it, but the needle is pushing the mass and it's shaking the mass and not moving through it, because the mass is very firm and located in the soft normal pancreas. Then what to do? Try to do a door knocking technique. You adjust the stopper 1 centimeter below the handle when you approaches the upper aspect of the needle. Then fix the stopper 1 centimeter below, and then start to do what is known as staccato movements or sudden repeated pushes. You know that voice, like knocking on a door. We tried several times, and as you see with me here, after applying door knocking technique, the needle is now starts to move inside the needle, to move inside the mass, and not shaking or moving the mass as a whole. Concentrate in that video. You notice now that we are starts to move inside the mass. So it is very difficult mass because it is small, so the range of movement inside is very limited. It is 9 millimeter. It is very firm and located in a soft normal pancreas. Now, very nice. We are now starts to move inside the mass. And fortunately enough, the cytopathological diagnosis was low-grade duct adenocarcinoma, and the patient underwent partial pancreatectomy. Now come to the complication. The complication is perforation, very rare, about 1 every 1,000 patients, and usually the perforation occurs between the first and second part of the duodenum. As you all know, when you go by the echo endoscope to the second part of the duodenum, you do right and up, like the movement of the fundus. Right by the right knob and up by the big wheel. When we will try to withdraw, to push the echo endoscope inside the second part, perforation may occur. So you should be very careful. And in small number of patients, and with marked inclination between the first and second part of the duodenum, sometimes it is very difficult to pass to the second part. In a little percent of patients, 1 or 2 or 3 patients every 100 patients, then you can screen from the bulb of the duodenum and from the stomach, as we mentioned in the previous webinars of examination of the pancreas from the stomach and the bulb of the duodenum. You can do it from station 3 and 4. The second complication is infection, especially in cysts, whether pancreatic or somewhere else. And when you do sampling of a rectal lesion due to the presence of the bacteria inside the rectum, so we should go prophylactic. We should give prophylactic antibiotics before sampling. One of the complications is hemorrhage inside the lesion, especially gastrointestinal stromal cell tumors, because it is a rather vascular tumor in contrast to leiomyoma, which is usually hypovascular, or neuroendocrine tumor. So try to sample the periphery of the lesion, and you should apply Doppler before starting sampling to choose an area with no marked vascularity. So you should sample an area with no significant vasculature inside. And of course, you should be sure that the platelet and INR and PTT are normal. One of the complications of EUS-FNA or FNB especially is pancreatitis. If you pass a long distance in a normal pancreas to reach a lesion, especially small lesions, if the lesion is small, 1 centimeter, then you should travel for some distance inside the normal pancreas, but you should are obliged to. So here, the advice is try to pass as short as you can through the normal pancreatic tissue to avoid pancreatitis. And seeding may occur, translocation of malignant vessels, higher in cystic lesion. In cystic lesion, try to do a single puncture and to do complete evacuation of the cyst to decrease the pressure inside, to prevent oozing of some fluid in the nearby tissue, to minimize seeding. This is an example of gastrointestinal stromal cell tumor. Here, with application of Doppler, there are marked vascularity or significant vascularity. This is the FNA, and this is bleeding inside. So try to sample the periphery of the lesion, not in the center of the lesion, and try to choose an area with minimal vasculature. This is one of my cases. This was a left suprarenal cyst. And after FNA, I found this fresh bleeding, hyperechoic fresh bleeding. And here there is a vessel inside. This is the bleeding vessel, very nicely seen. This is a bleeding vessel in a cyst. I observed the patient while the echo endoscope inside the patient. I waited for few minutes. The bleeding increased, but the bleeding vessel stopped. Thanks God for that. The bleeding increased, but the bleeding vessels stopped. Why? Because with bleeding, with continued bleeding, the pressure inside the cyst is increasing. So the high pressure inside the cyst will compress the bleeding point. So don't be afraid. Most of the bleeding inside a cyst will stop spontaneously. Just observation, no need for further intervention. because the continued bleeding inside the cyst increases the pressure inside and compresses the bleeding point. This is a video from one of my colleagues. I had the permission to put it here, and this is FNA sampling of a pancreatic cyst, and here we notice that there is a significant bleeding, and this bleeding, of course, it is an arterial bleeding because it comes in jets. Don't afraid, don't be panic. This bleeding will stop in near 100% of cases, because as I told you before, the pressure increased, and the increased pressure will compress the bleeding vessel, whether venous or arterial. Okay, now coming to the last part of the lecture, what is the different techniques of AUS tissue sampling? There are many points to be issued or to be raised. The first point, do you use stylet with or without the stylet? Most of the articles, most of the endosonographists show no difference if you use the stylet or not. But I prefer to use the stylet to prevent contamination of the sample by the gastrointestinal wall. Sometimes, especially in GIST tumors, when you pass from the wall to the tumor without a stylet, you can contaminate the sample by the muscle layer of the wall, and so the myocytes, the cytopathologist confused whether this myocytes is from wall contamination, from the muscularis propria of the wall, or from the GIST itself. Experienced cytopathologists can differentiate, and the immunohistochemistry can differentiate. The second point is to do a slow pull, low pressure or capillary technique, or high pressure technique by the syringe. Most of the literature says no difference, but what I am doing is to apply Doppler first before sampling. If the lesion is hypervascular, as in some GIST tumor and neuroendocrine tumor, I use the slow pull or low pressure technique to avoid bloody samples. And I show the first pass. If the material is enough, then I do the second and the third pass by the same technique. But if the material is too little, then the second pass I apply high pressure. And the opposite. If I apply Doppler first and the lesion is hypovascular or avascular, like in cases of pancreatic adenocarcinoma and leiomyoma, I start with high pressure. The first pass with high pressure. If the sample is not bloody, then I continue the second, the third part with high pressure. But if the sample is bloody, then the second pass, I use the low pressure or the slow pull pressure to obtain a non-bloody sample. How many passes? At least 3 passes. If you don't have rapid on-site evaluation, then you should do at least 3 passes. Fanning technique is very important because it raises the accuracy or the sensitivity of tissue sampling from 60% to 85%. We all know the fanning technique is to try to obtain biopsy from the central part of the lesion and also the peripheral parts of the lesion. You can change the course of the needle by the elevator or the lever, or by pushing the echo endoscope slightly inside the patient for few centimeters. This will change the direction of the needle from the center to the periphery or the opposite. So the fanning technique is very beneficial. MOSE, macroscopic on-site evaluation. Macroscopic on-site evaluation is to observe grossly the sample you obtained. If there are white or grayish parts, then it is very nice. It is a tissue. But if all the sample is reddish, then it may be a blood contamination. So when you find whitish material or grayish material, this is very nice and the sample will be enough. What about ROSE, rapid on-site evaluation? Yes, this is very important and highly reliable, with excellent agreement with final cytopathologic diagnosis. And actually, this is the best thing you do, is to have a cytopathologist beside you. But unfortunately, in most instances, the cytopathologist is too busy. So in my experience, in more than 80% of the occasions, I don't have ROSE. ROSE is available in only 10 or 20%. And I need ROSE if the first pass, or if not the first pass, if the previous biopsy is negative and the patient came for another trial of EOS-FNA, then I do every effort to provide a cytopathologist beside me for ROSE. So ROSE is very, very, very helpful if available. I think the most important factor in determining the yield of EOS tissue sampling is local or central cytopathologist. Experienced or inexperienced cytopathologist. This is, I think, the most important factor, and it is the most decisive factors. In many instances, I send the patient to go to someone, and the biopsy is inadequate, bloody, hemorrhagic, and when I repeat the cytopathology with an experienced one, that is called rereading or second opinion, it proved to be malignant and it proved to be cellular. So I think cytopathologists all over the world is a special art. So you should always refer your samples to an experienced cytopathologist. So the most important factors in increase the yield of EOS-FNA, fanning technique is useful, MOSE is useful, ROSE is very important, local or central cytopathologist is decisive. Now come to the last slide, or last two slides of my lecture, and the famous question and everyday debate whether to use FNA or FNB. Many years ago, there was a needle which is called the true cut needle. It is a 19 gauge needle with a spring-loaded biopsy. But it is not suitable for every site, especially in the duodenum, because it is 19G needle. And in the duodenal, the position of the echo endoscope is a long position, and the external part, the most distal part, the distal segment of the echo endoscope is usually bended, so it is difficult to manipulate a thick needle, 19G needle, with a bended external segment of the echo endoscope in the duodenum. And there is some complications, a little bit more incidence of bleeding. Now, in common use are the fine needle biopsy, are ProCore, Acquire, and Sharp Core. These are newer types of needle available to obtain a core histologic sample in order to improve diagnostic accuracy and important for immunochemical staining. Then what to use, FNA or FNB? In most of my patients, I use FNA needle because it is very manipulative, very easy to use, very easy to move with the lever, very malleable, very deformable. But in cases when I suggest that I need immune staining, I should do fine needle biopsy. Especially in cases of lymphoma, you should do CD markers, and in GIST tumor, you should do 117 and DOG1, and in autoimmune pancreatitis, you should stain for IgG4 receptor on the plasma lymphocytic cells. So the answer of the question, FNA or FNB, the first according to your preference. If you are used to do FNB, then use FNB. If you are used to use FNA, then use FNA. But if you are suspecting that the patient may need immunostaining, like in lymphoma, GIST, or autoimmune pancreatitis, you should do FNB by FNB needles. This is the types of FNB needles. This is the Procore, 2 types. Here the bevel is near the distal end, and here the bevel is away from the distal end. The size is 22, 25, 19 in all needles, but here another needle is 20, which is the recoil needle, which I think it is very good. When I decided to do FNB, I use 20G Procore needle. Now come to the take-home messages. EUS tissue sampling may be very valuable in endoscopic biopsy negative GI wall malignant looking lesions. Sampling of portahepatis lymphadenopathy may give an indirect evidence of hilar Klatskin tumors. Fanning technique, rapid on-site evaluation, and experienced cytopathologists are the most useful factors in increasing the yield of tissue sampling. You may do FNA or FNB according to your preference, but FNB should be done if immune staining will be needed to reach the final diagnosis. And thank you very much for your interest in endoscopic ultrasound, and thank you very much for your attention. Okay.
Dr. Hussein now, Dr. Mazen Naga.
Okay. Now I have the pleasure and honor to hear, as always, to my great professor over tens of years. He is the godfather of our unit of internal medicine department in Cairo University, and I have the pleasure and honor to share him this webinar. Professor Mazen Naga.
شكرا دكتور حسين.
Thank you, Professor Hussein Al-Kasha. I also wish to thank Scope Medical, the agent of Cook and Bentex companies, to give us a chance to communicate with our colleagues through this activity. ERCP is a science and art with handicraft. With training, we bridge the gap between the science and the art of handicraft. Now we have some cases to present. How can we manage ERCP easily and to overcome the difficulties of ERCP? Successful ERCP depends on proper scope placement and adequate visualization of the papilla. As we see here, the papilla must be in the center of the field or slightly to the left. This is achieved by placing the duodenoscope below the papilla. We must limit air insufflation and gastric distension, as this will may interfere with good positioning of the papilla. Shortening the scope in the second part before beginning cannulation. This provides the greatest maneuverability and keeps you near the papilla, because in short scope, the accessories, the wires of the scopes are not so stretched, so the accessories are easily mobile. Some fine adjustment of the scope can be done to allow the tip of the caster to enter the papillary orifice at perpendicular angle, orient the papilla and face to be near to the papilla, to have the papilla in the center of the visual field. Location. Sometimes it is very difficult to see where is the papilla. As example of this, normal anatomy, the papilla is on the medial aspect of the second part of the duodenum, occasionally found more proximally near the superior duodenal angle, and occasionally in the third part of the duodenum, the proximal part of the third part. In these cases, locating the frenulum of the longitudinal duodenal fold below the papilla can help to localize the major papilla. A caster or a sphincterotome can lift the duodenal folds, and you can see here how can we do this. This is an example of multiple folds, and we are looking where the frenulum is here. So there is two bulges, but most probably the frenulum is here, so we'll find the papilla below this fold. We see now it is very small below the fold. This is one of the difficult cases, but this is very important how to locate the papilla in between the folds, because in these cases, if you fail, you will not be able to cannulate the papilla. We remove the folds by the tip of the sphincterotome, and then we find a small bulge below, and we get inside, and then we cannulate the papilla. Fortunately, it was easy cannulation, because if we want to do pre-cut in the presence of all these folds, it will be a very difficult maneuver. Now we can see here below this fold, and the frenulum is here. We'll remove it with the sphincterotome, and the papilla we can find here the frenulum, and here is the bulge of the papilla below this fold. Then we put the sphincterotome in the right position and go to 11 o'clock position to get inside the papilla. Papilla in the third part of the duodenum, this is also difficult, because if the papilla in the third part, fixation of the scope in the proper position is difficult. Usually the scope falls back to the stomach, as we will see now. We pass through the pylorus by sunset appearance, passing through the pylorus without seeing the actual opening of the pylorus. Now here on the bulb, we go to the second part. We found this. This is not the papilla. This is the minor papilla, which is also abnormally located. Then we try to pass to the second part deep to the proximal third part, and we'll see how difficult it is if the papilla in the third part, both for not able to fix the scope in position. Second, as we will see now, the papilla is in abnormal location, making cannulation a little bit difficult. As you see, as we all see, fixing the scope, going deep, is not easy with the duodenoscope. It's not easy like the gastroscope to go deep in the second, third part. And now we can find the papilla here, but the location is shifted to the right and upward, which will make cannulation a little bit difficult. What we'll do now, first, to identify the orifice. As we see, several times the scopes fall back again, but at the end we'll succeed to get a little bit proper position. Sorry. Sorry, the fan has rewound again. It's not possible to make it faster. We must wait to see the position of the papilla and how can we cannulate. I didn't shorten the film to show how difficult, if the papilla in the third part, how it's difficult to locate and to find and to cannulate. Now here is the papilla, here is the frenulum below. The orifice is here. As we see, the position is not very easy to cannulate. We get the sphinctrum out, and then we bow the sphinctrum to be able to catch the orifice of the papilla, because if it is straight, we will not be able to get inside. This is what will you do? Use a short, small wheel to make counterclockwise rotation to the left, and then the big wheel counterclockwise to go up and straighten the sphincter, and we will get inside the common bile duct in spite of this difficult location. Positioning. The papilla must be some distance away from the scope and to the left. If the tip of the scope is too far away, the curvature of the sphincter will go to the roof of the papilla, making jamming of the injection and jamming of the wire. Don't force the catheter tip into the ambulatory segment. To advance the wire will cause progressive edema or create false track. If you try to inject the contrast material, it will either reflux into the duodenal lumen or will cause submucosal injection and edema and disorganization. Release the pressure on the catheter by releasing the lever so you can inject or advance the wire. To have a roadmap, inject very slowly and small amount to see the direction of the bile duct, the pancreatic duct. Avoid overfilling of the pancreatic duct to avoid pancreatitis. If you go into the pancreas, withdraw the catheter and try to cannulate from slightly different angle to get inside the common bile duct. Aim the accessory used to the orifice of the papilla, as we will see here, at 11 o'clock. Sometimes the sphincter is directed to 3 o'clock. If this is the case, use a catheter or use cylinder sphincter, which are more easy to direct to 11 o'clock. Put the tip of the accessory in the orifice of the papilla at 11 o'clock and push the scope to the papilla while the sphincter is unbound. Turn the small wheel counterclockwise to get to the left, the large wheel to counterclockwise to go up. The accessory will slide easily inside the common duct, and this will straighten the S-shaped intramural part of the papilla. If we fail to cannulate with the sphincter, we must shift to another method, which is wire-guided cannulation. In wire-guided cannulation, we use the angled hydrophilic guide wire 0.35 millimeter for easy cannulation. They have reduced friction and ease of pushing. They are able to follow the S shape of the interduodenal part of the bile duct and turn up into the biliary system. In case of stenosis of the orifice of the papilla, the guide wire is advanced just beyond the tip of the catheter. Then the catheter with the guide wire tip protruding is advanced in the biliary tree under fluoroscopic guidance. This is also done with the floppy or mobile papilla. So this technique can be used either in small papilla with stenosed orifice or floppy papilla moving, and we can't fix the papilla. Variant anatomy. A rare cause of failed cannulation is transposition of the duct where the bile duct is at 5 o'clock and the pancreas at 11 o'clock. This apparent orientation is most often discovered after needle knife sphincterotomy. In this case, we will find that the papilla is under two folds, which makes cannulation very difficult. And even needle knife is also very difficult to try to remove the fold and try to make the cut. We tried first with sphinctome with bowing and unbowing, but we failed. Then we shifted to the Sohendra 6 French dilator, trying to get into proper position, but also it was not possible. And after several tries, unfortunately, there is some deformation of the papilla with edema, making the shape of the papilla a little bit ugly. So now we shifted to use the needle knife sphinctome. When we use a needle knife sphinctome, it must be very short because we must cut the mucosa, not the muscle layer. We must cut the mucosa first to expose the muscle layer, which we know by the onion skin appearance. Don't go deep from the start, otherwise you will lead to perforation, because also we don't know the direction in which the papillary muscle is found. When we use this, we'll see we cut also from the orifice and directed at 11 o'clock. This is the usual place. Then we cut the mucosa, expose the muscle layer after several cuttings of the mucosa to reopen the muscle layer. We can see here below, but will be apparent more after cutting the mucosa a little bit more. Here, now we expose the muscle layer. Don't push in this recess between the mucosa and the muscle layer because we need perforation. You must start trying by trying at the muscle layer. And after trying, we didn't find that it's go at 11 o'clock. So we extend the cut in the opposite direction to 3 o'clock. Only the mucosa. And then we cut the muscle layer. Pushing again at 11 o'clock does not go. We tried with the tip of the wire. And after finding that it is not the proper direction, now we shift to 3 o'clock direction, cutting more of the mucosa, and then we get to cut the deeper muscle layer in the direction of 3 o'clock, and we will find that the sphincterome, the needle knife, goes inside the common bile duct, and when we put it outside, we see that it is at 11 o'clock. Sometimes a tumor or malrotation of the stomach push the papilla below, and we couldn't get it from below as usual. What we do, we start from above, and then we use the sphinctotome and bow the sphinctotome, try to push it into the 11 direction position, several manipulations until we could get, and then we can, after getting inside, we can straighten the sphinctotome. Other way, we can cut the roof of the papilla by the knife, but this may be difficult because of the position from above. And after finishing, we can pull the sphinctome to shorten the scope. Technique of sphincterotomy. For complete sphincterotomy, the cut is extended to the margin of the papillary bulge. Extension beyond the duodenal fold is not a problem, but in small papilla, the extent of the cut must be limited accordingly. We use 1/4 to 1/3 of the sphincterotome wire. If we put more than this inside the papilla, coagulation current and the papilla will swell by inflammation and edema, causing pancreatitis and making cannulation very difficult. So only 1/4 to 1/3 of the sphincterotome is used for cutting. Cutting should always be done with the distal part of the wire, minimal pressure and minimal bending for proper cutting. Endocut mode is used with sitting effect 3, duration 2, interval 3. The sphincterotomy should be completed to the end, because if we stop and try to cut again, if the edema occurs, the edges will be blurred. And we must see that there is no blanching of the edges, which means that there is overcoagulation. We must make sure that the cutting current is more than coagulation in this case. The opening may be assessed by the vein testing stone to withdraw outside the orifice, or by using the stone balloon to assess the orifice exactly. Otherwise, we may be impacted by the stone inside the small orifice. Sometimes a cut is made to try to extract the stone. We found that it is very small compared to the stone. What is the definition of difficult cannulation? More than 5 contacts with the papilla while attempting to cannulate. More than 5 minutes spent attempting to cannulate following visualization of the papilla. More than one unintended pancreatic duct cannulation or ossification of the pancreatic duct. What we do in this case, pancreatic guide wire assisted biliary cannulation, or 2 guide wire techniques. The European Society of Endoscopy recommended using pancreatic guide wire assisted cannulation in patients where biliary cannulation is difficult and repeated unintentional access to the pancreatic duct is done. The guide wire is left in the pancreatic duct. This straightens the intermolar part of the papilla. The S-shaped is straightened, and we can cannulate the bile duct easily. But in this case, prophylactic pancreatic stenting is left and must be checked after 1 week that it falls outside the body. This is an example of this technique of 2-wire cannulation. We left the wire inside the pancreatic duct. We must be sure that the wire is straight and not making curves and not going to side branches during all the procedure to avoid perforation of side branch and causing pancreatitis. This facilitates entering, and then you can complete the sphincterotomy very easily and safely. But when to do with the cut? In difficult biliary cannulation, absence of main pancreatic duct access, pre-cutting is suggested. Pre-cutting or persistent cannulation attempts have the same success, the same complication rate, but both ARCP pancreatitis is less frequent with pre-cutting. Don't delay the pre-cut until the papilla becomes very ugly and you can't find what to do. European Society of Endoscopy suggests placement of pancreatic stenting in this case, and to check it falls out of the body maximum by 1 week by X-ray. Now, an example of pre-cut papillotomy, and I bring this example because the papilla is small, which shows us the difficulty. In pre-cut papillotomy, the needle knife is used to deroof the major duodenal papilla to visualize and cannulate the common bile duct. The needle knife is placed at 11-12 o'clock position, papillary orifice, and cut upward along the midline of the interduodenal segment of the bile duct to expose the muscle layer, which is known by the whitish onion skin appearance. Usually, we use the knife to try to make the line to make sure that we can pass after getting the wire outside in the proper direction. We'll see now how can we overcome difficulty in small papilla. We cut, as in the previous case, first the mucosa to expose the muscle layer. The problem, because of the limitation of time, I can present some different morphologies of the papilla and some different morphologies of the papilla inside the reticulum. I stick to short presentations and shorten the presentation as much as I can. Now we cut through the mucosa. Still, the muscle layer is deep. We cut more. Don't go, as I told you, to the recess here. You must be over the muscle layer to be sure that you don't make perforation with the wire, because if you remove the mucosa, it's very easy to perforate with the wire. Now, we cut the muscle layer after cutting the mucosa, and we can get inside We try with the wire in the proper direction after cutting the muscle layer, and as we'll see, at last we get inside the bile duct easily. European Society of Gastroenterology Endoscopy recommends needle knife stylotomy as a preferred technique for pre-cutting. Suggests that pre-cutting should be used only by endoscopists who achieve selective biliary cannulation more than 80% of the cases. Endoscopists who does not reach this level must do this under guidance of a senior endoscopist to avoid complications for the patient. Fistulotomy in large bulging papilla with dilated bile duct due to stone impaction. The safest and simplest approach is needle knife fistulotomy. The needle is placed at the apex of the papilla and the cut is made in continuous fashion through the mucosal layers and into the duct. As with all needle knife techniques, important to perform a test maneuver as to determine the direction of motion before doing the actual cut. Once the duct axis has been achieved, standard sphincterotomy can be applied and increasing the opening. This is huge papilla, and this is a very easy example to show how can we cut and how can we expose the muscle layer. We start also by short needle to cut the mucosa, exposing the muscle layer. Here is the muscle layer. We see the opening here of the papillary orifice. We cut the muscle layer very easily, very large, very easy to cannulate with this technique pre-cut. And now we got at the 11 direction position very easily. This is another example of very easy because this is a pregnant papilla with stones inside. The stones protect us from making perforation because we cut over the upper surface of the stone, and we cut also the mucosa, not so deep in the spot we know that there are stones inside because this is more safe. Now we find the white color of the muscle layer, and when we cut this, we will see the stone slipping one after the other outside the pregnant papilla. Transpancreatic biliary sphincterotomy. This technique I avoid to use except when I find no other way for fear of pancreatitis. Transpancreatic sphincterotomy is recommended by the European Society of Gastroenterology Endoscopy in a small papilla in case fire get into the pancreatic duct unintentionally. The sphincterotome is placed in the pancreatic duct orifice with the cutting wire used to cut the upper lip of the mucosal orifice, what we call septotomy, to cut the septum between the pancreatic and the bile duct. We use only 2 millimeters of the wire. The small cut will allow change the axis facilitating deep bidirectional axis. This can be done only if the course of the pancreatic duct is free of angles. Also, one must be cautious of the pancreatic wire to avoid wire being advanced into side branch, which can cause perforation. Also, in this case, prophylactic pancreatic stenting is recommended. In case of periambular diverticulum, it obscures the papilla and distorts orientation. In case of diverticulum, the biliary direction is not angulated like the normal papilla, but it is horizontal. Therefore, there is no need to angulate the sphincterotome. Standard caster or cylinder dilator can be used for cannulation, using the ERCP caster to move the duodenal mucosal folds outer rim of the diverticulum ring, exposing the papilla. Pancreatic duct stent placement followed by pre-cut sphincterotomy by needle knife fistulotomy are suitable options. In case with EST technically difficult to complete, large stone removal can be facilitated by large balloon dilatation after small sphincterotomy. Another method includes injecting at the floor of the diverticulum to move the papilla outside the diverticulum. However, this technique must be cautious because of high risk of needle perforation, retroperitoneal leaks, and sometimes causing edema of the papilla subsequent obstruction of the papillary orifice. This is an example. Most of the cases, the papilla is here. Sometimes it is here, sometimes it's here. If it is here, it is very easy. Here, it is very difficult. Unfortunately, I didn't present so many videos because of shortage of time. Now, we get the needle to inject inside. First, we get the needle outside the Teflon, and we inject before touching the posterior wall to avoid perforation or retroperitoneal leakage and to get submucosal edema to lift the papilla outside. And then the orifice now comes in view we use cylinder 6 French dilator with the tip of the guide wire, and then we push the guide wire in horizontal position, not upward, not bowing the sphincter. And when we get to the wire freely, we push the sphincter, and then we can complete the sphincterotomy very easily. Cannulation of the sphincter and sphincterotomy in altered anatomy in patients with gastrectomy. ERCP should be performed in a referral center without viewing duodenoscope first. If not successful, pediatric colonoscope or balloon enteroscopy as a second choice. A straight or standard ERCP caster or inverted sphincterotomy, cylinder Barrow's sphincterotomy, with or without the guide wire, recommended by the United European Society of Endoscopy for periopancreatic cannulation in patients who have undergone Barrow's gastrectomy. Needle knife is used for sphincterotomy over 7 French stents introduced in the bile duct to confirm the direction to avoid perforation and the extent of cut. After removal of stent, balloon sphincteroplasty can be used to expand the orifice. In patients complex post-surgical anatomy, referral center is better than ordinary center. How can we choose a loop? The afferent loop and the efferent loop. The efferent loop is usually in front of the scope immediately in gastrogenostomy. It is a little bit to the left and below in the afferent loop, and to check the position, we must see on the X-ray that we have inverted question mark all the time, not going deeply with the scope. This is first point. And now we'll see how can we cannulate the papilla in Barrow's 2. Here, this is the minor papilla, not the major papilla. As we go deep, nearly to the pylorus, and then we retract the scope back. We are fortunate that there is a short loop. Then we get the major papilla here, and we'll find the orifice here. And then we use cylinder 6 French dilator or straight cannula because it's more easy and we successfully get inside the bile duct. Cannulation of the minor papilla is just above the major papilla and slightly to the left. Why do we cannulate the minor papilla? If there is stricture in the endoscopic bile duct, we couldn't find the pancreatic duct, we must cannulate the minor papilla to be sure that there is no pancreatitis or cancer here of the pancreas. And in case we know that there is pancreatitis, this is the only way to get inside the pancreatic duct to facilitate endotherapy. This is the minor papilla. We get also with 6 French the cylinder dilator with a tip in 12 position, 12 direction. And how can we got this? We retract the scope outside counterclockwise and then push the scope up to get the papilla in view. And then we push the wire inside, several manipulations until the wire get inside. In this case, we'll find that the X-ray showed us that this is a incomplete pancreas division at both the dorsal and the ventral pancreatic ducts are opening into the minor papilla. Another example of cannulating the minor papilla in case of pancreatitis, as we see here also, we use the 6 French cylinder dilator and we use the tip of the wire. We get inside with the tip of the wire and then with the 6 French dilator. And when we are using the X-ray, we confirm that we are inside the pancreatic duct. Here, the major papilla is just beside the minor papilla, which is a rare finding. Usually, it is higher up. Now we find that the pancreatic duct is marked dilated with stricture here. Then we leave the wire inside, as we will do endotherapy, to do sphincterotomy, and we'll put inside several plastic stents, or as we now use covered metal stent, which will lead to dilatation, but most probably surgical management of strictures of pancreatic duct is better because the recurrence rate is very high. Now we do sphincterotomy in the 12 direction position. This will be followed by putting a stent inside. and then several stents, plastic stents, which is more cheaper in our country than putting self-expandable metal stent. The stent in pancreatic duct must not have inner flap to avoid trauma during extraction to the pancreatic duct. We must only put big flap outside, but not flaps inside. Multiple orifices are found in the pancreatic duct stent. Thank you very much.
Then thank you, Professor Mazen Naga, for this very valuable, very dedicated, very professional lecture. We learned a lot from your broad and very efficient experience in ERCP. Thank you very much. And now we will shift to my dear colleague, Dr. Shayma El-Kholi. She is specialized in third space endoscopy, and she will talk about ESCD, when to do.
Hello, everyone. This is Shayma El-Kholi from Cairo University. I'd first like to thank Scope Medical Company for this nice webinar, and to thank Professor Akasha for the kind invitation. I know that we are far beyond time, so I'll try to be very fast. It's really a mess to give a lecture after Professor Naga and Professor Akasha, so I'll try to do my best. I would like to welcome my dear colleagues from different parts of the world. As we can see here, we have friends from every part of the world: China, India, Indonesia, a lot of parts from the world. I'd like to introduce myself. I am a gastroenterologist from Cairo University. I work in the POIM and EST team in Cairo University. And Professor Akasha asked me to give a very basic lecture about EST, and we choose to when to do EST. Actually, when we started our program 2 years ago, we were just like digging through a wall. We have a lot of difficulties and barriers. We have some financial issues, we have some technical issues, and also we had maybe issues with the surgeons. But what we have noticed recently, that we have issues with the referring doctors from our colleagues. We get a lot of referrals, but these referrals are usually not fit, maybe too small lesions for ESD, maybe advanced lesions for ESD. That's why we decided to learn together which lesion is suitable for ESD. So before we talk about ESD, we have to know from which ESD emerged. It emerged from EMR, which is endoscopic mucosal resection. As you can see, we just substitute few letters and now it becomes ESD. So just a gentle reminder, what is EMR? EMR is a snare-based resection. It's either you inject and cut the lesion, or you suck and cut the lesion. EMR is safe and feasible. It's usually done by maybe most of the endoscopists, and you can do it at ease. But you can see this lady here. This lady is not happy with the EMR. Why? Not because she's a lady, and ladies are always arguing. Because EMR, it's not suitable for large lesions, as you cannot get in-block resection. So you will not have safety margins, either vertical or horizontal margins. Besides, there is a risk that will be a residual lesion, and this residual lesion may lead to recurrent lesions. And EMR is not suitable for non-lifting lesions, and it's also not suitable for recurrent lesions or any lesions with submucosal fibrosis. So if you just give it a little bit of thinking, of course, not like this guy thinking, it's just the limitations of EMR is indications for ESD. So here are the steps of ESD. ESD is, maybe most of you know, it's just you localize your tumor. You start by marking the lesion, then submucosal injection. Then you do circular incision outside the marking, and then you start dissecting below the lesion till you get your lesion in block. And this is the advantage of ESD. So here's we start with a video that will show the steps of ESD. Here is a female patient, 42 years old, who presented with GI bleeding. And during gastroscopy, this lesion was found. It's obvious that this is a submucosal tumor. And EUS was then showed that it arises from the second layer. And here's the video. You can see here's the lesion is on the lesser curve of the stomach, just below the esophagus. We start with marking using APC. I hope that the videos are okay. You start to mark the lesion, and afterwards, here's the marking complete. And afterwards, you start injection. We use methylene blue mixed with saline. After injection, we get the knife we will dissect with, and we start doing the circular incision. It's not mandatory that you complete the whole circular incision. You can leave a final part till the final dissection. And here you can see that we are performing the circular incision and it's almost complete. Then we start dissection. You can see here's the submucosa looks blue. I hope you can see the video clearly. And then we go below the lesion where we go for dissection. The lesion is on the left side. And we are just below the lesion and we are dissecting now. The submucosa has a very good affinity for the color. So it is the blue layer. This is the submucosa. Here is a very, very nice picture where you can find the lesion is on the left side. Here's the lesion that looks white. And here is the submucosa where we are performing dissection. And we are here almost near complete. We can use this needle also to inject. As you can see, there is a little bit of submucosal fibrosis below the lesion. And then we go on dissection. Oh, and then we encounter bleeding. If it cannot be controlled with a knife, we have to control it with a coagulation forceps. And here's a successful control of bleeding. And afterwards, it's almost done. It's just the final cut. Here we shift to the IT knife. This IT knife has an insulated tip knife. So we dissect with the shaft of the knife. As you can see here, that we are separating the lesion. And here is our final cut. So here's our lesion. And after that, it's very important to go to the bed back to be sure that you secured all the potentially bleeding blood vessels and your clean bed. And this is our lesion. Here's the pathology. It's a well-differentiated neuroendocrine tumor. And what's most important when you see the pathology, that you have to contact your pathologist and know if there is a free margin or not. So if we speak roughly about ESD, so it may be indicated for large lesions, maybe more than 15 in the esophagus, more than 20 elsewhere in the GI. ESD is indicated for lesions where EMR is not feasible, like recurrent lesion, residual lesion, non-lifting lesion. ESD is indicated when lesions, suspicious lesions that should be removed in block, because we have to get our safety margin, whether horizontal margin or vertical margin. Actually, this is very roughly speaking, but maybe we need to go a little bit deep to know which lesion is liable for endoscopic resection. So just a basic reminder about GI cancer and the wall or the layers of invasion to the GI cancer. Here's the wall of the GI. Here's the mucosa composed of epithelium, lamina propria, layer, and submucosa, the muscle layer, then adventitious serosa. If you have a lesion or cancer that is confined to the epithelium, it's called carcinoma in situ. When it starts to invade the lamina propria of the layer, it's T1A. When it goes to the submucosa, it's T1B. And then when it goes to the muscle, it's T2. To the adventitious serosa, it's T3. To the surrounding is T4. This is very important. This is the cornerstone of which to refer. Here you can see that endoscopy is limited to T1A and TIS, or T1A, and surgery from T2. So we have to know this by heart. Starting from T2 is out the scope of endoscopy. What about the submucosa? What about T1B? Why did I left it like this? Because the submucosa, they have classified it to T1B into 3 layers. the first 1/3 of the submucosa, the second 1/3 of the submucosa, and the third 1/3 of the submucosa. And actually, what's debatable is the first, which is SM1. This is the first 1/3 of the submucosa, which can be liable for endoscopic resection. But on what basis do they choose that T1A and T1B SM1 are candidates for endoscopic resection? It's all about lymph node invasion. It's all about the risk of lymph node invasion. As you can see here, when you go from esophageal cancer to gastric cancer to colorectal cancer, if you go through the mucosa M1, M2, M3, you can see that the instance of lymph node metastasis is around 0. We have to bear in mind that these numbers are not strict numbers. It's just a range of numbers, but it's usually around 0. When it comes to the esophagus here, maybe the instance is a little bit higher. So when you go to SM1, you find that the instance of lymph node invasion is a little bit higher. It can reach to 17%, provided that it's 200 micron. And for the gastric, it's 0%, but it's 500 micron. And for the colon, it is the whole SM1. So if we classify the indications here, we will find that in esophageal cancer, M1 and M2 are just an absolute indication. But when it comes to M3 and SM1, it's a relative indication. When we go for the stomach, also SM1 is a relative indication or extended indication. And then, and for the colon, it's free. So it looks like when we move down through the GI tract, things are getting a little bit looser or easier. So the rule that you want to get from this lecture is, as you go down from the esophagus to the colon, you can go for deeper resection. So as you go down, you can resect more deeply. Okay, but it will not be practical if I bring all the guidelines in one lecture. I will need series of lectures. I just want to show you that it's not only the depth of invasion that is regarded as an indication for EST. In each organ, we have an extra thing. I'm giving just an example. It's not the whole guidelines. And I will show you the links of the guidelines at the end of the presentation where you can go and check by yourself. For the esophagus here, this is adopted from the Japanese guidelines 2020, that they added the circumferential involvement of the tumor, whether it is circumferential or not, to decide if it is for endoscopic resection or surgery. And here's for the stomach. Here's the ECGE and the Japanese guidelines both. They didn't depend only on the depth of invasion. They also added the presence of superficial ulceration, the size of the lesion, with whether it is differentiated or not. Here is a very interesting case. This lesion in the antrum. It was referred to our center after a trial of EMR in another center that failed. So we did an EUS and shows that this lesion is arising from the 3rd layer. And here we are doing the steps of ESD. We start by marking. As you can see here, we use the MBI mode in the marking because this is a surface lesion. This is an adenoma. It's not like the other lesion that we have showed. It is a submucosal tumor. Then after marking, we can do injection. And then afterwards, we will go for the mucosal incision. And here's the circular incision is almost complete. And afterwards, we will go for dissection. And we usually start the dissection by deepening of the circular incision. It makes the lesion retracts. One of the problems that will be encountered during EST in this lesion that is a little bit larger than the other one, that it will always just get over you while you are dissecting. So there are a lot of methods or techniques that we can use to retract the lesion and go behind. As you can see here, it gets smaller. And here is a clip retraction method where this is a dental fluff that is attached to a clip. And then it is attached to the edge of the lesion. And you let your assistant gently push the dental fluff, just forming a flap for you so that you can go down and you complete your dissection. At the end of the dissection, you can see that we have dissected the lesion completely. And this area in the middle is just submucosal fibrosis from the other trial, from the previous trial of resection. And here is the lesion. The lesion was shown to be completely benign. It's a tubular adenoma and a low-grade dysplasia. And of course, it has a free margin. So when it comes to colon is actually one of the most forgiving organs. Here is a statement stated by the ECG. It states that most of the colonic lesions or polyps can be removed by the standard polypectomy or EMR. And the ECG just confined the ESD just to measure two indications. First, for the lesions that may show suspicious of submucosal invasion and lesions that are not optimal for EMR. But maybe the Japanese were a little bit more bold and they put a lot of indications, maybe regarding bilateral spreading tumors, suspicious lesions, lesions with submucosal fibrosis, lesions with chronic inflammation, residual or recurrent lesions. And here you can see this is a laterally spreading tumor. This is the classification of the laterally spreading tumor. You can see here the lesions. This is the granular type, this is the non-granular type, and the granular type is classified into homogeneous and mixed, and the non-granular type is classified into flat and pseudodepressed. You can see here the lesions, the lesion looks very nice, and then you go down, this nice is disappearing. So for the first lesion, it can be removed with either piecemeal EMR or ESD according to the local experience, but of course ESD is much preferred because we want to get the lesion in block. But as you can see, as you go down here, the instance of invasion or the instance that this lesion carries a malignancy is higher. So as you go down, the indication of ESD increases. So here is a very nice video about a patient who has a laterally spreading tumor. It's a granular, it's a mixed type. And can you see, when you see here, this is the granular part. And when we apply the narrow band, you can see here, this is the flat part. I hope the videos are okay with you. And then we will go with the classic techniques. We will start with marking the lesion. It's very important to mark the lesion here with the narrow band as part of the lesion was not already obvious before the MBI mode. And it's very important that you clean your field very clearly and you inspect every part with narrow band or chroma endoscopy just to guess if there is a suspicious invasion or not. And as we finish our marking, we see that the lesion is big. It's occupying about 70 or 75% of the circumference. And then after the marking, we will go with the circular incision. As you can see, first injection, of course, and then with the circular incision. As you can see here, the circular incision, it's very nice demo because you just cut outside the marking so that you get a very good safety margin. And you can see here, after the circular incision, we start to go beneath the lesion. You can see this lesion, the submucosa is not very healthy. It's not like the blue, very good, nice one that we have demonstrated in the other two cases. This is because this patient has an ulcerative colitis. And then we go on for dissection. Of course, there are a lot of tips of tricks that we can talk about in colorectal ESDs. That first, you have to put the patient in a position where the fluid becomes an independent part. And here, there's the final cut. And then there is the lesion bed. The lesion is finally excised. And then, of course, you have to ensure hemostasis. This lesion is a raw area, big raw area, with a very, it may have a post-ESD bleeding. So here's our lesion that was removed in block. And then when we go for the pathology, it is a tubular adenoma with areas of tubulovellus adenoma with high-grade dysplasia. And there is a single focus of cancer, and it was invading to the SM1, and it has a free deep submucosal margin, which means that after we resected the SM1, there was 2 millimeter free zone of cancer. Here is the final diagnosis, where it's SM1 with 2 millimeter free vertical margin, and of course the horizontal margin was free. So my take-home message that ESD is to large lesions, suspicious lesions, lesions where AMR cannot be performed. It's no longer that all cancers are referred to surgery because we see a lot of malpractice where patients with carcinoma in situ, after removing it, it goes for surgery. It's not for surgery from the very beginning. You have to remember that our limit is T1A. T1B is an extended criteria, or it's controversial. You have to check your lesion in details, and you have to know the layer, very important. And remember, as you go down, you can resect more deep. And at the end, you have to have a dedicated pathologist for the ESD, and you have to communicate with him. And finally, stay safe, stay at home. This is our team, and this is our dedicated pathologist, Dr. Dalia, and this is our backup surgery, Karim from Cairo University. These are the links, and thank you.
Then thank you very much, Dr. Shaima, for this very nice, valuable, really informative lecture. And I'd like to thank my dear Professor Mazen Naga, and I'd also to thank deeply Scope Medical Company, the official agent of Pentax and Cook Egypt. And now it is time of free discussion and asking questions. Mr. Ashraf El-Bouhi and Mr. Adil from Scope Medical Company will control the process of asking questions. Please.
Before starting our discussion and the questions, I'd like to thank all the participants. Special thanks for our distinguished professors for their elegant, comprehensive, and informative lectures and illustrations. And very special thanks for those participants from different countries. They are from more than 50 countries all over the world. And now we are going to start our first question for Professor Hussein Okasha. Is there difference between linear and radial echoscope in diagnosis of subepithelial lesions? This is from Dr. Muhammad Shaheen.
Yes, a very nice question. There is no different diagnosis, but in the radial is more easy. Radial echoscope is easier than linear in diagnosis of submucosal lesions. But if you have both or more experience with linear, after doing 50 to 100 cases, for example, you will be very easy to characterize and to diagnose submucosal lesion. Both are very effective, are very variable, no difference, but the radial echoscope easier at the start, in the beginning. But the most advantage is a very valuable role of linear is to obtain FNA if needed. So if I have a choice to buy one endoscope, I will buy a linear one. If I have another budget to buy another echoscope, I will buy another linear one. Because if the previous one or there is an in the maintenance, then I have another one. So in my lecture, the first slide is the main task, and the most valuable role of endoscopic ultrasound is tissue sampling and tissue acquisition, the linear one. Because in most cases, as I mentioned, tissue is the issue. So if you have a linear one, don't bother yourself to be panicked. Just do cases, reach out 40, 50 or cases, and you're very acquainted with submucosal lesions, and there is no difference at all between the linear and radial one.
Second question. For an unknown solid pancreatic mass, you recommend an FNA or FNB? Which gauge?
Pancreatic?
Pancreatic mass. For unknown solid pancreatic mass, would you recommend an FNA or FNB? which gauge?
Yes, a very good question. Yes, a very good question. If the mass is straightforward or looks like a pancreatic adenocarcinoma, you can diagnose it, suspecting it strongly by just the endoscopic picture: obstructive jaundice, head mass, hypovascular mass, hypoochoic mass. Then it is mostly a adenocarcinoma, which constitutes about 90 to 95% of all pancreatic mass. Here, FNA is very efficient, as FNB. Both are equal. If you are acquainted, or if you are your preference is FNA, do FNA. But if mass is somewhat typical, are suspecting lymphoma, or you are suspecting immune pancreatitis, the patient is have another autoimmune diseases, the pancreas is sausage shaped in the 5% of cases, then you should do FNB. But in most instances, the picture is very informative or very impressive of pancreatic duct carcinoma. To both are equal in about 90% of cases. Atypical cases, as I mentioned, when you are expecting lymphoma or autoimmune pancreatitis, then you should FNB, because you should do immunostaining. So you should do FNB. So most of the pancreatic cases I am doing FNA. The echo-tip needle, very malleable, very easy to relate with the lever, the elevator. So I am very comfortable with FNA. But at the end, as you are your preference, many of the colleagues doing sampling by FNB. All are FNB. This is his preference, but my preference is FNA. FNA needle is very malleable and very easy to manipulate in the duodenum. But I refer to FNB if I am think that I will need immune staining, as I told you, in pancreatic masses suggestive of lymphoma or immune pancreatitis.
Next question is for Professor Mazen Naga from Professor Tahir Zanati. In papilla within diverticulum, usually there is an anomaly in papillary muscle, either very short or malrotated. How we can avoid perforation?
In papillary inside diverticulum, the European Society of Gastroendoscopy recommend putting a stent inside and then cutting over it. But I don't do that. Usually, I cannulate with a regular sphincterotome and then very short cut, except if I see the whole papilla. Unfortunately, the time does not allow me to present several cases of different views of periambular diverticulum, because this is variable. Maybe on the right side, which is there, maybe on the left side, which is more common, and maybe on the floor, you can cannulate directly, or looking the orifice to the other side. There are many different shapes, but as long as we are inside with the guide wire sphincterotome and the wire is inside the common bile duct, I can make a shortcut followed by balloon dilatation to avoid perforation if I can see the upper limit of the papilla.
Next question for Professor Mazen. How to differentiate submucosa and sphincter muscle to avoid perforation during pre-cut sphincterotomy?
As we see in the videos, we shorten the needle as much as possible, and we start by cutting the mucosa. Even submucosa is cut during this procedure to expose the muscle layer. The main issue is that we must not push the cannula with the tip of the guide wire into the recess formed by the retraction of the mucosa to the outer side. We must restrict our functioning to the muscle layer, which is completely directly under the mucosa. So when we cut the mucosa, if we didn't expose enough of the muscle layer, we cut more. We can cut up to the upper limit of the papilla to expose the muscle layer. There is no risk of perforation. Then we cut the muscle layer as we want. But avoid to try to use the wire in the recesses formed by retracting the submucosa to the sides, because perforation is very easy at that time.
Thank you, Professor Mazen.
Thank you.
Next question is for Dr. Shaima.
Yes.
Dr. Shaima, is there any underlying fibrosis in UC patients led to more difficulty in ESD, or
Yes,
it is,
of course.
or it is
Yes,
like
yes, of
in
course.
other patients?
No, of course, this patient has a mucosal inflammation, and it is expected that he goes into a lot of attacks of exacerbations. So there is, by default, an expected submucosal fibrosis. That's why patients with ulcerative colitis, they are mentioned clearly in the Japanese guidelines that whatever the size of the lesion, it should be removed in block.
Next question is from Professor Khalid Hamida to Dr. Shaima. What is the incidence of stricture after EMR, especially after removal of large circumferential lesion in esophagus and colon?
Could you please raise your voice? The
What
incidence of stricture?
of stricture after EMR, especially after removal of large circumferential lesions in esophagus and colon?
Actually, the incidence of after circumferential lesions for EMR is not that high like ESD, because in ESD we use a lot of coagulation, and we can also use an APC. But there are a lot of trials that these patients can have an oral steroids that should be started immediately after the procedure. And sometimes when stricture happens, we can give them an intralesional steroids.
Okay, next question is for Professor Hussein Okasha.
Can you please raise your voice?
Okay, thanks.
Dr. Ashraf, please raise your voice.
Okay.
We cannot hear you clearly.
Is it must to use a stopper during the EUS-FNA of thickened stomach wall with an impressive malignancy for the concern of potential peritoneal seeding?
Please repeat the question.
Is it a must to use a stopper during the EUS-FNA of thickened stomach wall with the impressive malignancy for the concern of potential peritoneal seeding?
Yes. That's a very intelligent question. You mean that we use the stopper to prevent past pointing of the needle outside the gastric wall into the peritoneum. So you may translocate some of the malignant cells from the gastric wall to the peritoneum.
Exactly.
Yes. Actually, I don't use the stopper at all, because my little finger is the stopper. I don't use the stopper in usual cases, because I am fixing my little finger at about 5 or 6 or 7 centimeter, and it acts as a stopper. And my index finger and my big finger are doing the movement to and fro movement. I use the stopper only in 2 cases. The first case I mentioned in the lecture, in the knocking door technique, because I am doing successive severe pushes, so I should fix the stopper 1 or 2 centimeters below the handle, according to the size of the needle, to do this staccato or strong pushes. The second situation which I use the stopper is when aspirating a pancreatic cyst. I am entering the cyst, start aspiration, and I fix the stopper because I will spend up to 10 minutes in aspirating the whole content of the cyst. So in a trial to avoid any unexpected movements of the patient or of the nurse, so I fix the stopper to prevent past pointing of the needle to go out of the cyst to the opposite side. But in the usual cases, in most of the cases, I use my little finger fixing the shaft of the needle and acting as a stopper. This is in most of the cases.
Thank you, Professor Okash. Next question is from Dr. Abdelbasit Al-Khamri to Dr. Mazen Naga. When you do indifferent cannulation of the pancreatic duct, how you decide to do either double guide wire cannulation of the CBD or transpancreatic sphincterotomy?
I rarely do transpancreatic sphincterotomy because the hazard of pancreatitis, although we are trying to do septotomy only, is greater. So I leave the wire inside. I then cannulate the bile duct. But if the papilla is very small, and especially also if it is under a fold, which means that leaving the wire inside make it more difficult to cannulate again, so I do transpancreatic sphincterotomy. Also, if the papilla is malrotated to one direction, making positioning also difficult, then I will do transpancreatic sphincterotomy. Small papilla under a fold, mal-directed, but in also if the wire is not deep enough inside the pancreatic duct to avoid that the wire making kink and slips outside, or to make perforations in the pancreatic duct. So if the wire is not long enough inside the pancreatic duct straight, this is the third indication to do transpancreatic sphincterotomy.
Thank you, Professor Mazi. The next question is for Dr. Shaimaa. In case of non-lifting lesion due to fibrosis or by previous biopsy or EMR, how to differentiate this from invasive before performing ESD?
Yes, this is a very good question, and I will take a little bit time to answer it. Basically speaking, whether this lesion is fibrosis or recurrent or not, how to identify that this lesion is malignant, and how to identify the layer. I know that in the guidelines that it's not mentioned that we use EUS, but actually we use EUS to identify the layer of the lesion. And we think this is mandatory according to our experience to know the exact layer that will help you in knowing provisionally if this lesion is benign or malignant. But what is much more important is to use a high definition scope. The use of high definition scope can help you in detecting if there is an invasion or not. So it is recommended in the guidelines that you never do ESD or EMR without the use of high definition scope with narrowband or chroma endoscopy. We had a lot of classifications. We have Paris classification, we have the NICE classification, and also we have that the NJAT, or sorry, the GNAT, or the Japanese classification. It helps you to roll out the invasion with the presence of a special surface pattern. But if we go deep, that we have a lot of other classification system according to the blood vessels that are apparent on the surface. And if you allow me that to share you a little bit, can I share my screen again, or we don't have more time?
We still have time.
Okay, so as you can see here, this is the IPCL-AB classification. It gives you an idea about the exact layer and whether the depth of invasion. Actually, this needs a lot of training, and it depends on the capillaries and the looping of the capillaries. And also we have another system, or another classification system that's called EVA, which is the avascular area. And also it helps you to give you an idea about the depth of invasion. But these lesions, these systems need a magnification endoscopy, and this magnification endoscopy is not available in Egypt. So we don't have other options. So we will have to depend on the surface, on the surface that I mean roughly from the chroma endoscopy or from narrowband, and not from the blood vessels. that we can use the Kudu classification, we can use the NJET classification, we can use the NICE classification, of course, the Paris classification. Okay, thank you.
Okay, thank you, Dr. Shaima. For Dr. Okasha, from Dr. Salim Salim, can you explain the difference between...
Please raise your voice again.
I'm sorry, maybe this is a device. Can you explain the difference between door knocking technique versus capillary technique in FNA?
These are two different techniques. Capillary technique is a low pressure technique, I mentioned it. Low pressure technique or capillary technique or slow pull technique, these are synonymous to the same maneuver. Where the capillary technique, when you enter the mass and doing the to and fro movement, at the same time your assistant is withdrawing the stylet 10 by 10 centimeter. So you are creating a very low pressure inside the needle. This capillary technique or low pressure technique or slow pull technique is very suitable for vascular lesion to avoid bloody smears. If you apply high pressure to a vascular lesion, then we'll suck more and more blood with dilution of the specimen, and finally it will be inconclusive. So as I mentioned, capillary technique or slow pull technique or low pressure technique is very suitable for vascular lesions, as some cases of gastrointestinal tumors, GIS, or neuroendocrine tumor. But the knocking door technique is another technique for another situation. When you find that the mass is very firm, and after you piercing or entering inside the mass and starting to do to and fro movement, you find that the needle is not moving inside this hard mass. When you move the needle, it does not move inside the mass, but it is shaking the mass as a whole. So no biopsies were taken. By then, you should apply the door knocking technique. Successive staccato pushes in order to push the needle to move inside that hard lesion. So these are two different techniques in two different situations.
Okay, thank you, Professor Akasha. Next question is for Professor Mazen from Dr. Ahmed Dawood.
Please raise your voice again in every question.
Okay. This is for Professor Mazen from Dr.
Yes.
Ahmed Dawood.
Yes.
Did you use surgical clips to help in cannulation of CBD if the ampulla is in diverticulum?
Yes, I use it sometimes, but as we all know, eclipses are very expensive now in Cairo. So I prefer to, in the condition like this, to inject in the floor of the ampulla more cheap with the needle. But we can use it if there is redundant folds to fix the folds to bring the ampulla outside. But now, not so common because of expense.
Thank you, Professor Mazen. Next question is for Dr. Shaima.
Yes.
What is the rule of ESD in Barrett's esophagus?
What is the rule of course, when there is a suspicious lesion, if the lesion is like nodules that are less than 15 millimeters, this is according to the guidelines, it can be removed safely with EMR. When there is a suspicious area that there is a deeper invasion, it should be removed with ESD. And if it is more than 15 millimeters, it should be removed with ESD.
Dr. Hussein Okasha?
Yes.
This is from Dr. Ahmed Mustafa. Sampling of nearby portahepatic LN may help us knowing nature of
Sampling of nearby. Yes. Raise your voice.
portahepatic LN
Lymph
may
node,
help
yes.
lymph node may help us knowing nature of proximal hilar stricture. What is
Yes.
the rule of cytology brushing, especially if I don't have spyglass?
Yes, it's a very important question. If the patient underwent ERCP before for application of a stent or something like that, and you find a hilar stricture, then you can do brush cytology or bile cytology. But unfortunately, the yield of brush cytology is very low. It is about 30%, and the false positive is high. So it has a very low sensitivity and also low specificity. So at the end, you should have another technique for tissue sampling. In case of hilar stricture, here of choice is cholangioscope or spyglass. And then comes EUS FNA in the third place. But if you don't have, if the brush cytology is negative, and usually it is negative, so some professors do not do it from the start. They are saying, why I am not doing a technique which is maybe costly and have a very low sensitivity and rather low specificity. But some are doing brush cytology. But you can reach the diagnosis in only 30% of cases. So you need another modality for tissue sampling. In case of hilar stricture, the first choice is spyglass and cholangioscopy. And in distal stricture, the first choice is EUS. But if you don't have spyglass or cholangioscopy in your section or in your institute, and there is no other facility to refer it to another unit, then we come to the third option, which is endoscopic ultrasound, which also usually fail to obtain biopsy from the hilar lesion, because in most instances, up to 80%, it is in the form of just wall thickening. But to overcome this, we can sample a nearby lymph node. If it is Klatskin tumor, hilar cholangiocarcinoma, in most cases, there is a nearby lymph node because it is a malignant lesion. It is very easy to sample the porta-hepatic lymph node, as we saw in the videos in the lecture. And if it is positive, this will be a very useful indirect sign of malignancy of this hilar stricture. We did many cases. We reach now up to 37 cases of hilar stricture diagnosed by malignant porta-hepatis lymph node. 37, but 37 cases over about 15 to 10 years of working in endoscopic ultrasound, and it represents about 50% of cases of EUS done for hilar stricture. In 50%, we're in Klatskin tumor. In 50%, we can find lymph node and very easy to sample, and the cytopathology is very accurate, so we can reach the diagnosis indirectly in 50% of Klatskin tumor. Probably after reaching a large number of these cases, we can publish it, but till now it is just an advice to sample nearby lymph node because it is the most available in most cases.
Thank you, Dr. Hussein Okasha. Now to Dr. Mazen Naga from Dr. Muhammad Nabil Qadi. When to stop trial of cannulations?
We usually stop trial of cannulation if we found that the papilla is deformed and we will be more harmful than successful because the incidence of both ERCP and pancreatitis will be increased by more manipulations. But this is not usual. This is very rare because after a trial of cannulation, usually we shift to pre-cut, and the success rate in pre-cut only maybe 2 to 3% of the cases shifted to pre-cut are failures, which means that success rate as usual cannulation is around 90%. 10% will shift to pre-cut, 2% of them will fail, and then we shift to another maneuver like BTC or rendezvous technique or to EUS with rendezvous technique.
Next question is for Dr. Shaima from Dr. Ashraf Abu Bakr. How do you know if the layer of invasion in areas far from EUS axis? And
Yes.
if you accidentally find the muscle layer during ESD, do you continue?
Yes, this is a very good question. Maybe I partially answered the question from the previous question that it's not the EUS that we usually depend on when we want to characterize the lesion, but it is usually very helpful when it is in the ES axis, right, in the esophagus or in the stomach or in the rectum. But the question comes when the lesion is in the proximal side of the colon, on the right side of the colon, or on the transverse colon, or maybe on the left side where the ES is not accessible. Here we have mainly to depend on the high definition scopes and the use of narrowband and the use of classification, and we can roughly estimate the depth of invasion, or at least we can exclude invasion. So this is how we depend. If we have magnification endoscopy, it will increase the sensitivity up to more than 80% to detect the layer of invasion.
Thank you, Dr. Shaima. And
yes,
now
about the second part of the question is when you find, if you find invasion, yes, we will have to go on, provided that we are fully equipped with, because we started the lesion, we cannot stop, but we have to go on and we have to complete it, because sometimes there is a fibrosis that can be mixed as an invasion, so we have to go on and complete the lesion. And the final decision will be to the pathologist to decide whether this was really an invasion to the muscle layer or it was just a fibrosis extending. But it's an advice that we perform tattooing of this lesion, because afterwards, if we found that it was a little bit more invasive, so it would make the surgeon job much easier if we do a tattoo.
Thank you, Dr. Shaima. Next question is for Professor Mazen Naga from Dr. Mahmoud Gouda. In case of a short part of the guide wire could pass through the papilla, but not kinking and not passing through the CBD, can we inject a dye to be guided?
Yes, this technique of roadmap we use if the wire does not pass enough inside, but we must make sure that we inject slowly and small amount to avoid overfilling of the pancreatic duct. The problem is that we must repeat very cautiously, because every time we inject again, we have the same problem again. But what we can do, if we have two screens beside each other, one for working and one for fixing the photo. So we inject a little bit, we have the roadmap, fix it on the other screen, and then we manipulate according to the position seen on the fixed screen.
Next question is for Dr. Okasha.
Can you get close to the laptop, please, Dr. Ashraf, because we barely hear you.
To Dr. Hussein Okasha from Dr. Mumtaz Hussein. What is your experience in sampling portal vein for cold biopsy of cancer cells to pick up early pancreatic cancer? How safe is it to transverse the portal vein?
Yes, I didn't do it, and I am not so encouraging to do it. It is safe, but I think this maneuver is not so asked. No one requesting this. Requesting portal vein sampling. Maybe there is no such research in Egypt, but portal vein sampling is rather safe. But really, I didn't do it before. But it is easy. It can you reach it through segment 4, through the right lobe of the liver. But I didn't do it before, and some are doing sampling of portal vein thrombosis, thrombus inside the portal vein before transplantation to know whether it is a malignant thrombus or benign thrombus. But I think very good quality CT scan, triphasic CT, very good quality MRI, very good quality especially CT with reconstruction, and it can solve the problem without the need of doing this maneuver. It can be done rather safe, but no one asking for this technique so frequently. And I think regarding portal vein thrombosis, good quality triphasic spiral CT with reconstruction and IV contrast is enough to differentiate benign from malignant thrombus.
Thank you, Professor Okash. And now to Professor Mazen from Dr. Osama Salim. In case you put a pancreatic stent, what is the length and size you use? How frequent you check on it? When to remove?
There is two pancreatic stents. One has a prophylaxis against pancreatitis. This is 5 French stent. And I put short stent to fall rapidly. The main aim is to avoid blocking the pancreatic duct from the early edema occurring during sphincterotomy. So no need to stay longer. Usually I check for it by X-ray after 1 week. The other stent is that used for treatment of strictures in pancreas and chronic pancreatitis, and this I will leave for 3 months.
Thank you, Professor Mazen. For Dr. Shaima,
Yes.
concentration of the methylene blue and saline for elevation of mucosa in ESD from Dr. Fatma Adil.
Yes, we use 9 millimeter of concentrated methylene blue on a 500 cc saline.
Thank you. For Dr. Shaima also, do you use EUS before doing ESD or not, for elevation?
Of
I am
course,
watching.
Professor Okash.
I'm watching your answer.
Of course, we use EUS before everything, before meals even. Of course. Especially if the EUS is from Pentex, we have to use it every.
Thank you.
Of course, Professor Akasha will kill us. As you can see, that from our local experience, of course, it's not very huge experience, but we usually perform whenever accessible EUS for all lesions, because we have to assess the lesion very thoroughly. We are still gaining experience, and we think that EUS should be performed, and even performed by experts.
Okay. Thank you, Dr. Shaima.
Yes.
Another question for you from Dr. Tahir Zanati.
Yes.
Why you mark the lesion before submucosal injection? Can we inject first to be sure that it is lifted before marking?
Yes, very nice question. Actually, we don't depend on the lifting sign. It could help, but the sensitivity and specificity of the lifting sign had proven to be of little value if you want to detect the lesion is benign or malignant. So it's better that we already had taken the decision to remove the lesion before we try lifting. This is very important, especially if we don't have the ESD equipments around. If we try to lift the lesion first, and then we found that, oh wow, that's lifting, so we will remove it somewhere else, it will cause an extensive submucosal fibrosis. So lifting sign is a good help, but it's not sensitive or specific. We have to depend on other things like ES, like the external morphology of the lesion, to take the decision whether to resect the lesion or not. About marking the lesion, we have to mark the lesion first, because before starting the dissection, everything looks calm, there's no blood, there's no blah, blah, blah. So we have to define the actual margin between the normal tissue and the abnormal tissue. So we can put our margin, because once we start the injection or putting the needle, or once we start the dissection, everything goes with blood. It's not that clean like we have showed in the videos. It's an edited videos. So these marks will remain our guide till the end of the procedure.
Thank you, Dr. Shaima. Next question is for Professor Mazen from Dr. Mustafa Kilani. What is your opinion, Dr. Mazen, about limited sphincterotomy and balloon dilatation of papilla?
Yes, we use this in case of large stones to preserve some of the sphincteric function to be able to remove the stones. So we do limited sphincterotomy to avoid pancreatitis and to inflate the balloon above the pancreatic orifice to size comparable to the bile duct diameter, and then we can remove all the stones. And this is preferable to lithotripsy, because lithotripsy must crush all the stones. But if you balloon dilate, you can extract all the stones by single balloon dilatation. No need for crushing multiple baskets.
Next question is for Dr. Okasha. Patient diagnosed endoscopically to have adenocarcinoma, CT showing regional lymph node enlargement. Is this a case indicated for lymph node EUS biopsy?
Yes, the patient is already diagnosed as gastric adenocarcinoma. Those patients were sent for staging, not for biopsy, of course, because it is already diagnosed. I don't sample primary first station lymph nodes because it will not affect the diagnosis. But if there is a secondary station lymph node, I should sample, like celiac lymphadenopathy or mediastinal lymphadenopathy. But this policy has changed in the last few years. Now the guidelines for surgery or neoadjuvant chemotherapy is stage T1N0. So in order to do surgery for esophageal or gastric, the patient should be T1 or T2 without lymph nodes. If it is T3 or T4, or there is a nearby lymph node, then the patient should have neoadjuvant chemotherapy and then surgery. So nowadays, when I am doing staging of the patient and I find it T1 or T2, and then T1 or T2, then I go for node, then I should sample it, because if it is a malignant, then the patient should go for a neoadjuvant chemotherapy. Now the neoadjuvant chemotherapy has a great role. Neoadjuvant chemotherapy, the word neoadjuvant means preoperative chemotherapy for downstaging and then surgery. This is the meaning of the word neoadjuvant. So neoadjuvant chemotherapy are now given for all malignant tumors more than T2 or have any first station and of course the second station's lymph node. So when the patient referred to me for staging of already known case of adenocarcinoma and I find first station lymph node, this may be inflammatory or desmosplastic lymph node, which are commonly found in malignant lesions, or it may be a metastatic. So I should sample it, because if it is positive for malignancy, then the patient should have neoadjuvant chemotherapy before radical surgery.
Thank you, Professor Okasha. And now, unfortunately, everything has an end, and we are about to end our meeting. And before ending this really interesting meeting, we would like to thank our distinguished professors for their elegant, comprehensive, and informative lectures and illustrations. And thank all the participants who had spent their time, especially those who are so far from Egypt. The time there may be after dawn, 6 hours. And thank you all. Thank you, professors. Thank you all the participants, and looking forward our next webinar very shortly. Thank you.
Thank
all.
you very much.
Thank you very much.
Thank you very much.